Dr. Leonard and I are here on behalf of the Education Committee of the Pediatric Section. And so we have the pleasure of having our moderator today, Dr. Jeffrey Blount, who's the professor in chief of the University of Alabama here, to kind of lead this discussion. So thank you, Dr. Blount, for agreeing to do this. And thank you to our speakers as well. For agreeing to take their time out tonight and discuss this. So I'll hand it off to you.
Well, thank you, Toba, and thank you for the opportunity. This is a really great opportunity. I'm going to do a proper, introduction here in just a moment, but I'd like to lead off with sort of an anecdotal comment. And that is, I remember when I was at the junior resident stage and that sort of coming up stage where I remember some of the best moments when I got to attend the pediatric section, which has always been an exceptionally important meeting for residents making important decisions about what they want to do, were some of the engaging conversations where maybe not everybody saw things in exact perfect alignment and someone would challenge someone else over something. And it was always, I mean, I can still reflect back now and see those memories just as crystal clear as some of the most important ones of my own growing up and childhood. And I think we have the potential for that here, this evening, of a really memorable and important conversation at this point in time, because, spina bifida remains a very, very important problem. The publication and dissemination of the MOMS trial and all of its implication has fundamentally changed the landscape of this. This, for those that aren't aware, the attention within organized neurosurgery was sort of shrinking a little bit in terms of spina bifida. If you go back and just look at abstracts submitted and papers published in our journals, even the pediatric section, the number of papers addressing spina bifida was going down, and things like epilepsy and things like that were kind of coming up. So there was a little bit of a settling and a quieting of spina bifida, and then along comes the MOMS trial, and it was just literally an epiphanal moment for care for dysraphism, for our specialty, as a whole. So this is really an important topic. It's very timely, and we're extremely fortunate this evening, to have Dr. Wellens, Dr. Whitehead talk about it, right? They're both leaders in this field. Both are accomplished pediatric neurosurgeons at esteemed places, and both have been have brought forth seminal work in this. And what I love about it is that they're both really independent and very substantial thinkers. They think about things before they do them. I've known them both for years. They're both roughly my generation, and we're really privileged this evening to have them discuss such an important topic. So our featured speakers, the proper introduction: William Whitehead, professor of neurosurgery at Baylor College of Medicine; Jay Wellens, Cal Turner Chair and Chief of Pediatric Neurosurgery at Vanderbilt. And these two speakers will discuss the different ways that different programs treat prenatally myelomeningocele patients, and we can anticipate an overview of their perspective of indications, outcome measures, and other important components of the discussion in terms of our approach to these patients. After they've each had an opportunity to present a short presentation, we'll have some conversation that I'm privileged to pose some questions for. So I think we're in for a real treat here. So my understanding is that Dr. Wellens will be leading us off. So with that introduction, Jay, it's great to have you. Bill, it's great to have you. Jay, would you like to share your presentation and start your slides for
Yes,
us?
sir. Are you able to see my slides now?
Yes,
Yeah.
very well.
All right, let me get this guy out of the way. Okay. Okay, great. Well, thank you, Jeff, and Jeff Blount. And it's good to have you here. And also, the work that you've done recently, really not recently. I mean, when I was at UAB, you were already championing spina bifida, but the work that you've done internationally has also taken the care of children with spina bifida to the next level. And so you deserve a great deal of credit from our field and our field leaders. So thank you for that. And to Jeff Leonard and Toba, you guys have shouldered this for a while, the doing of the of the webinar and organizing. And it's a terrific way for us to, promulgate education, to our fellows and to ourselves. And so thank you for doing it. It's really important. Also, Dr. Whitehead, this does not count as any of my 20 minutes. Okay, so to begin, I I can remember when I was at UAB on faculty, and it was 2012, 2011, late 2011, and John Kessel called me and said, the NIH is about to release a missive that says that the mom's trial had to be halted. And I was like, aha, I knew it. I knew there was going to be a problem. I knew they had to halt it. And he said, no, 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 no. They halted it because it was so positive. I was like, what? He was like, yep, it was so in favor of fetal surgery that they stopped it. There's a press release coming out, and the word is they're going to send it to the New England Journal of Medicine. And I think that our field was in pediatric neurosurgery was caught a little bit unaware. And I remember being like member at large or something at the pediatric section and having so many of members stand up and talk about, well, what should we do? Should we have single centers that do this? Should it be like, I think Mark Swadan quoted Ayn Rand. I mean, it was a really fascinating conversation. In the meantime, after moms came out, there's been a steady progression of how the surgery's done, what the publications have been. And so I just want to take a little bit of time just to kind of talk about, some of the, Bill and I talked up front that I would talk a little bit more about moms and he would talk a little bit about selection. And then about the areas or how we tend to do it at our different institutions. So I'm going to figure out how to move my slides forward. Talk amongst yourselves. Okay, disclosures.
Muted.
Um,
You can make it pleasant for you. Do you want a paper towel?
Michelle, I think I can hear you, so you might want to mute yourself. Michelle Weidemeyer. Either that or I do not need a paper towel. Thank you. So this is Newell Tulipan, and for those of you who knew him, he was kind of a quiet giant in the field. Noel was really a terrific person, and I don't feel like I have the right to give any talks about fetal surgery without mentioning Noel and what he did. I always tell the residents, if you want to see the CV of somebody who has basically walked down a problem, look at Noel's CV, because it started with doing this in the lab with rabbits, and then it moved to trying this fetoscopically initially and failing, trying fetal hydrocephalus, ventricular amniotic shunts and failing, and then finally fetal surgery beginning to be successful. And he really was not the person that took a lot of limelight. He really was not the person that shined the spotlight to himself. But I think he deserves a great deal of credit within the field. Simultaneously, this was also being developed at CHOP by Scott Asdick and a pediatric surgeon and his colleagues there, Lee Sutton, and also at UCSF, Dr. Dana Farmer, and I was about to say Sanjay Gupta and Nalan Gupta over there. But just to speak a little bit about the Fetal Center at Vanderbilt, it's really fascinating to see. Let me see if I can make this smaller. It's really fascinating to see the development of fetal centers. Initially it was 1/2 day a week to 5 days a week. Yeah, thank you. And now it's around 3,000 patients a year. If you look to the left of the screen, you can see Noel here on the left, and Joseph Bruner on the right, and a guy named Bill Walsh. So these two were doing the surgeries, and Bill Walsh, the neonatologist, said, hold on, these babies are getting born early. We need to figure out how to do a study to look at it. So whenever I put a picture of Noel and Joseph and Joe Bruner up, I always add Bill Walsh because it shows kind of the importance of who's involved in this work. It's the pediatric neurosurgeon / the fetal surgeon. It's the MFM and it's the neonatologist. And, now 30 years later, Noel would love the fact that it took an army of people, to basically replace the work that they were doing. But fortunately, there's been some also evolution in the field. All types of fetal anomalies are dealt with in a fetal center. You can see, cystic hygromas and occipital encephaloceles and sacrococcygeal teratomas and omphaloceles and so forth. But it's important to note that other than twin transfusion, at least as of right now, and I know that our Brazilian and actually Bill's group has done a deeper dive in occipital encephaloceles, there's really no other area that can be impacted by fetal surgery. It's also a non-lethal defect, and that's important because that's involved in kind of the decision making about how we deal with these patients and how we talk to families. Now we say it's a non-lethal defect, but we also know that children that have spina bifida do have an earlier mortality. There are other issues that come up for it. Come up from it. Certainly, Chiari-2 is when it's symptomatic can be quite terrible. But it's important to note that really it's the main operation done at a fetal center. But it's also important to know, just from a enterprise building effort, that these are the fetal cardiac consults that you look at it since 2012, the number of cardiac consults that go up just in the process of having a fetal center, and then the number of operations that come from a fetal center in the cardiac world. It represents, I think, 7% or some small percent of the proportion of what they do, but it's still, every cardiologist or every child now that has a cardiac defect, 98% of them here have a cardiologist assigned to them before they are born. And so we like to think about that in the same way with all fetal anomalies. Here's an MRI scan. You can see the fetus here. For those of you that are spine oriented, you'll notice there's no anterolesthesis here. Thank you very much. But you can see the ventricles are slightly dilated. Then as you come down, you can see the lesion here on the back. It looks kind of like maybe a kind of an L5S1. This is not the exact same patient, but you can get a general sense of a child with hydrocephalus and that lesion. But we know that this lesion is quite different from this lesion. And so how do we make a decision about how to take care of those patients? And that's what's led to the MOMS trial. So the MOMS trial, I know many of you know this, but it was a randomized trial. It was based on shunt outcome, or actually there was a group that adjudicated this that decided based on a priori criteria if the child would have gotten a shunt based on that a priori criteria, or they should not have gotten it based on the a priori criteria. There was a composite outcome that was on shunt that was combined of shunt placement and death. If that gives you some sense of where shunts fall on the scale, I'm not sure, but that was the composite outcome. And like I mentioned before, it was published in 2012 in the New England Journal of Medicine, and you can see the major players that were a part of that group that published that. Just to talk a little bit about the operation that we do, and then I'll talk a little bit more about MOMS. This is the layout of the room. There's a lot of people in the room. One of the things that I like is that this is usually where I stand. Here's where one of the MFMs stand, another one of the MFMs stand, and then on this position here is our neurosurgical trainee. So whether or not it's a fellow or a PGY3 or a PGY6 that's on our service, they're at the table with the rest of us, and they're a major part of the operation. Occasionally, we'll rotate in a plastic surgeon if we're doing flaps, and if I have time, I'll talk about that at the end. This is Dr. Bennett, who's making the exposure in the uterus. You can see the opening in the uterus there, and with the ultrasound. And just to show a little bit of an up close, this is a larger one than we make now, but it's a good way to show you the kind of the anchovy of the splayed out spinal cord there. The method that we do here is we dissect out the spinal cord, roll it up. We put either we sew it with Dura, but if the Dura is like wet tissue paper, which it often is, we put a piece of Duraform on there and we close up the skin. And I've just kind of candidly or funnily called the Tulipan method, not published or anything on that. I just like to say that. because basically it takes about 20 minutes to do. It's a placo dissection, check the dura, patch or close, dissect the skin, quick decision for flaps, close the midline, and patch rotation defects if you need to. So that means if we have to make incisions laterally and swing something, swing a bipedicle flaps to the middle, then we sew some quick flex HD on the sides. If we do that, it expands the time to around 40 minutes. But the important part is that this is very reproducible. Most surgeons that come watch this kind of look at me and go, "Really? Is that kind of what you do?" Because it's small, and yes, it's like wet tissue paper, like I said, but it's a lot less steps than what we do when we do an open myelomeningocele, and it takes a lot less time. And I think that's also reduces the impact or the likelihood of having early birth. And that's what a typical closure looks like. So, just talking about the mom's trial itself, 19 to 25 weeks is when the surgery was done. We talked about the outcomes. This is the primary outcome here, which shows that 68% that had intrauterine surgery ultimately went on to have a shunt versus 98% in postnatal surgery. The actual placement of a shunt was even less, 40% with intrauterine surgery versus 82% with postnatal surgery. And you can also see here, I just look at the p-values. I hope John Kessel's not on this, Whitehead, but the degree of hindbrain herniation, super significant statistically. The degree of the brainstem kinking, very significant in favor of intrauterine surgery. Same thing for psychomotor outcomes. It's important to know that this psychomotor outcome was a second primary outcome, which is a rare thing in statistics. But it was a combination of the Bayley's mental developmental index and a difference between motor function and anatomical levels. So if there were one or greater than two levels better, that was felt to be a positive outcome, and that was noted to be quite positive in the mom's trial. The mental development index, you can see, was not different at all. Now, what about the Bill Walsh, the neonatology stuff? So you can see that chorioamniotic separation was higher in the prenatal surgery group. I mean, look at that, 20 to 0. And then oligohydramnios and spontaneous membrane rupture, all of that quite positive in the intrauterine group. You can see spontaneous labor. You can see gestational age at birth, both in weeks and in the number when it's categorized in 4 different kind of time epochs there. So the bottom line is that both adjudicated and actual shunt placement was better in the intrauterine group, motor level improvement, and it didn't go from like 20% to 100%, but it did double the motor level improvement from 20% to 43% in the intrauterine group. And then spontaneous labor was higher in the intrauterine group, and gestational age at birth was lower. So one of the things that we published, I think in my 2013, no, we did it in 2013 and finally got published in 15, was we tried to understand kind of the second study from the moms. We did this second study from the moms data to understand these prenatal predictors. I'm going to try not to get bogged down in this because I can talk about this for hours. But the most important thing that we found in order, like when we're sitting with people in a consultation in the intrauterine, in the fetal surgery group, a room, consultation room, is that ventricle size was the thing that mattered the most. Okay, that's in the from the mom study itself. So that means if the ventricles at the time of consultation were less than 10 millimeters, then the likelihood of needing a shunt was 20% in the intrauterine group versus 80% in the postnatal group. You can see it's 45 versus 86 when the vents are a little bigger, and then greater than 15, there's not really a big difference. And when you subdivide that out, that's not statistically significant. There are also postnatal predictors, and I'm going to skip through that just to say, why in the world was it so different when it was adjudicated? The a priori things that were agreed upon about when a shunt would be placed, and then versus when an actual shunt was placed. And basically, it was, if you looked at those criteria, which I skipped through a little bit quickly, it was when infants didn't have split sutures, bulging fontanelle, or sunsetting eyes, the incidence of shunt placement was reduced, and that implied that neurosurgeons tended to rely on those clinical signs to guide shunt placement. So what that means was even if a child had a head that was at the 99th percentile and their ventricles were big, if they didn't have a bulging fontanelle or sun-setting eyes or split sutures, surgeons were less likely to put a shunt in. And that's what explains that difference between, and I'm pointing with my finger like y'all can see it, but the difference between primary outcome and actual shunt placement. Then this was a very important paper that was led by the mom's investigators. That I tell you the bottom line is that it disconnected this concept of ventricle size from the motor outcome. So what that meant was when you counsel patients, you can counsel them about ventricular size and whether or not they would get a shunt based on those criteria, but it was independent this issue of their anatomical level improvement. And then this was a very important paper that came out in 2021 that I think about if it would have been, available to us in that room when everybody was standing up in 2012 trying to figure out what to do in our field. This is kind of the holy grail. This says basically that there were more kids that were walking community distances, 51% from the intrauterine group versus 23% from standard postnatal repair. And what this means is it is sustainable, right? And that's the most important thing at the end of the day. So a few notes, the culture of CSF diversion has changed. There's been a ton of papers on ETV CPC. I think it's important to note that a lot of centers have reduced the incidence of preterm birth. We did that through a technique modification that reduced it. We compared our group to the mom's intrauterine group, the fetal group, and it showed much less in terms of chorioamniotic separation and premature rupture of membranes. In terms of tethering, we tried to look into tethering, and we really don't know. But what we have, if there's more tethering with intrauterine surgery versus postnatal, there was certainly an implication that there was more, but it wasn't statistically significant in the mom study. But there's been publications from CHOP and other institutions showing that there have been dermoids that have been seen. So what we really wanted to do was see if there's a way to tell if there's any difference in MRI appearance between fetal closed patients and those that were done postnatally, and if there was any difference in tethering rates. And we blinded a radiologist, just temporarily, and also had to review the EMR, and there was no way to tell the difference between like neural tissue to fascia, neural tissue to skin, presence of an epidermoid. Those things were not different between prenatal and postnatal groups. And I think that's really important because if you remember, this procedure that we do is not closing a bunch of layers together. It's wrapping the spine, it's closing the spinal cord, just kind of rolling it up and putting a piece of Duraform on there and making sure the skin has a good closure. And if you look here, the body does the rest. It's quite phenomenal. And then large skin defects, like we talked about, Noel and Bruner, Joe Bruner published this way back in 2005, kind of doing this technique, but we added the placement of the Flex HD grafts there. And basically, we looked at this most recently up until 2021. And as noted, the operative time was increased, but the gestational age was the same. And as we changed over time, it really reduced our dehiscence rate substantially. And we had a very low bar to call something dehiscence. Even if the skin was open up a little bit, we called it that. But the surgical dehiscence rates that require going back to the OR were substantially changed. And that's something that we published in JNS Peds about a year and a half ago. And then it's nice to have the opportunity to train other centers. We had the opportunity to go to Australia and also, Toronto to be able to help do those first open fetal myelomeningocele cases there. And I also have Texas Children's because that crew came and visited Dr. Tulipan. I wasn't there in June 2011. And I wouldn't have taken Whitehead out to dinner, had I known what I know about him now. But at any rate, Texas Children's came, and a lot of places have come, and it's been a real pleasure to be a part of that. So with that, I think I'm hitting around 20 minutes, but I'll stop and I'll hand it over to Dr. Whitehead. I have some other slides that we can discuss if need be, or if I get personally attacked. But at this point, I think I'll stop.
Jay, that's a great summary. Wonderful program, and I think it's really important that you usher in an awareness of a little piece of the history of this, because the people like Noel Tulipan really were quiet, leaders, and very admirable in their dedication and their contribution. And you've picked this um, yoke up and have really, since going to Vanderbilt, have made this sort of your flaming sword, and it shows. And it was a very nice presentation. And I think most of the residents are aware, but there are different techniques, right, for endoscopic closure. And this is one of the areas where there's conversation and controversy. Is the so-called open technique that Dr. Wellens just shared with us was the technique utilized in the MOMS trial, standardized between the three centers, CHOP, Vanderbilt, and UCSF. And then there's been an evolution, and we're going to hear now. Dr. Whitehead has been a really thoughtful leader in terms of the endoscopic, or properly termed fetoscopic, management of myelomeningocele repair in utero. So, Bill, without further comment, would you be so kind as to share your presentation?
Yes, Jeff, and thank you. Can you see my slides right now?
Very nicely, yes.
Great. So thanks, and it's great to be here. Thanks for asking me to do this. I'll just share a few of my memories of when the MOMS trial came out as well. I was surprised that it was beneficial. I wasn't really interested in fetal surgery, but at Texas Children's, we had a fetal center that did procedures on a regular basis, that was really led by pediatric surgery. And when the MOMS trial came out, there was a big push to start doing myelomeningoceles, and neurosurgery got involved, and that's key to any successful program. But my initial role was to counsel patients about the risk and of fetal surgery and the safety of a postnatal repair, to make sure that they were choosing it with their eyes wide open. They would call me the naysayer on the team. And that's an important thing that I always remember too when I think about my career. This was something like doing fetal surgery. I never trained for it, didn't know much about it, and now it's a big part of what I do, and I really enjoy it. And initially, I didn't want anything to do with it. So as you go through your career, roll with it. The other thing I was going to say, I was going to thank Vanderbilt for helping our center, but Jay Wellens has already done that for me. But then the last thing that I think is impressive about the fetal surgery group is when they did this trial, only 3 centers did the surgery, and all the other fetal centers in the country would not do it. So patients could not go outside the trial to get the procedure. They really focused on running a trial and showing it was either beneficial or harmful before they opened it up in the United States. And hats off to them for doing that. I think it's the right way to do it, and they've done it in other things as well. But it took about 8 years to do the MOMS trial. And during that time, there was really no innovation. But they showed that it was beneficial. And so when we started in fetal surgery, we went with endoscopic, and endoscopic was a way to try to decrease the risk of the procedure specifically for the mom. So when I say we started doing endoscopic, it was a big group. You can't do this by yourself. Neurosurgery has to be involved, but if you don't have support from maternal fetal medicine, pediatric surgeons who are kind of the founders of fetal surgery, your outcomes aren't going to be as good. You need anesthesia, you need radiology, you need the teams in the spina bifida clinic. And so everything I'm going to show you today in terms of outcome is a result of the work of the people on this slide, plus many others who I just couldn't include. We do it endoscopically. We haven't done an open procedure for, I think, since 2018 now. This is what it looks like. This is an intraoperative photo. It's me with two other maternal fetal medicine surgeons. The one on the left is holding the baby, has his hands around the uterus and is stabilizing the baby in a mixture of amniotic fluid and CO2 gas. And that's a critical part of the procedure because there's no, it's hard to stabilize the kid. And you're working from just two access points. And then I'm working through one port doing the dissection, and then on the right of the screen is Dr. Belfort, who's also an obstetrician, and he's holding a channel endoscope. He can put a 3mm instrument through it and help me. And it's like I'm one hand and he's the other, and then Shami is the operating room table, and all three people have to work together. And it's difficult. So the question is, why would you do this? And the reason to do it is to avoid the hysterotomy. There are two patients in this operation. The one we think about the most is the baby, but there's also the mom, and she bears a lot of risk for no direct benefit. And this hysterotomy, which is done to get access, has consequences for maternal health. So open fetal surgery was pioneered back in the 80s and 90s by Michael Harrison at UCSF and his group and the group in Vanderbilt. It was just done for a few procedures and the group in Philadelphia. But since the MOMS trial was published, there's a lot more open hysterotomies being done worldwide. And that has consequences for the moms. And that's what, if there's the most important thing I'll say about doing endoscopic is it's done for the benefit of the mother. Because the mother carries an increased risk as a result of this procedure. It's an opening at the top of the uterus through the fundus. It's the thinnest part of the uterus, and it's also called like a classical cesarean section. Usually when you do a C-section, the baby comes out, but in this surgery, the baby stays in, continues to grow, it's moving around. There's pressure on that incision, and it's smooth muscle, so it doesn't heal well. So there's a risk of rupture during the pregnancy. So a lot of babies are delivered early to decrease the risk of going into labor. And if you go into labor, you have to be delivered because if there's a rupture, it really puts the baby and the mom at risk. And then all future pregnancies have to be cesarean section because there's a risk of rupture with those pregnancies as well. And then there's this rare condition, but life-threatening condition for mom called placenta prurita. And that's when the placenta implants in a subsequent pregnancy and can grow through the C-section incision. And when that happens at the time of delivery, there can be bleeding. The placenta doesn't separate well, and that puts the mom's life at risk. It's not very common, but one of the biggest risk factors for it is the number of cesarean sections. So those are the things that drove fetoscopic. It was really driven by maternal fetal medicine doctors. This is an intraoperative picture from a delivery of a myelomeningocele baby. The uterus was exposed and delivered through a low transverse uterine incision. And then when the repair hysterotomy, which is at the top of the uterus, was evaluated, there was this adhesion, and then underneath that, a dehiscence. And this is what we're trying to avoid. In the MOMS trial, about a third of the women had either a very thin area at the repair site or a dehiscence or a complete dehiscence. And about 10% of these women who have a hysterotomy are at risk for rupture or will rupture their uterus with the next pregnancy, somewhere between 4 and 9%. And that was shown nicely by this registry in NAFNet, where they recorded data for women who've had the myelomeningocele repair, and then looked at women who've had a subsequent pregnancy. And there were about 60 of those pregnancies. And in those 60, there was about a 10% risk of uterine rupture. So there were 5 cases, and then 2 of those ruptures resulted in fetal death. So it can have significant consequences for the sibling as well. These are not deaths in the myelomeningocele baby, it's deaths in the sibling. And I will say that this data is a little bit old. A couple years ago in the registry, they've updated these numbers, and they are improving, but the risk is still there. And this is an illustration of what placenta percreta looks like. Maybe you can see my pointer. This is just an example of the placenta implanting on a previous C-section site with the placenta kind of growing in through the uterus and then being invasive into the bladder. And when that happens, when this baby delivers and that placenta tries to separate, there can be a significant amount of bleeding. So these are all risks for the moms, and that's what drove the program. We wanted to do fetoscopy for maternal health reasons, but the disadvantages of doing fetoscopy, I'll talk about more, is the surgery is longer. You have to do frequent monitoring. It's technically more difficult, and two-port fetoscopy has to be learned. It's not like endoscopic nerve ventriculostomy. There's some similarities, but it's different. It's not even like laparoscopy where you have 3 ports or sometimes more, and you can use both hands to dissect. This is really a unique technique that takes practice to develop, and you've got to work closely with 2 other people. So the procedure is pretty much the same as an open hysterotomy, except we don't make the hysterotomy. We place 2 ports, remove amniotic fluid, and sublate with humidified CO2 gas. Once the first port is put in, we'll take a look at the lesion and position the baby. We make a decision about closure, which is almost always to close, but sometimes we see things that are unexpected, and we might abort at that point. But then a second port is put in, and we do the repair. And the technique for the repair is modified some compared to a postnatal repair. First step is still to untether the placode, like you would for a postnatal. You just untether it from the skin, and then I'll lay a bovine collagen patch over the placode, and then fashion these myofascial flaps. And these are myofascial flaps with dura. You can see them on the right. And Greg Hewer in the group at CHOP was the one who first published this. It has led to a much lower rate of CSF leak, and reversal of hindbrain herniation numbers have improved since doing that. We saw the same thing when we incorporated it into our fetoscopic repair. So credit to them. And then we undermine skin and try to do a primary closure of the skin. We can do that about 80% of the time. If we can't, then we do relaxing incisions like Tulipan described, and Jay showed those papers, and that's our closure. And this is a video that quickly shows it. You can see the placode there. And one of the things that I'm always impressed with fetal surgery is how clean the planes are and how little inflammation there is. The dissection and and what we see, it's a lot easier than a postnatal repair, where we tend to see a lot more inflammation and the planes aren't as clear. So that was the dissection of the placode, and then this is cuts through the dura and the fascia, and we usually do the 4 quadrants with the bovie. And we'll raise those flaps and move them medial, and then this is that patch that goes over the placode. And I do this not to prevent tethering. I don't think it does, but it protects the placode from the sutures that I'm going to throw next. It keeps the placode in the spinal canal. It's another layer. It's easy to lose track of what's placode and what's muscle sometimes, so this keeps it pretty clean. And then these are 3 oviparals that we use to close the muscle. And then those knots are endoscopic knots that are tied outside the uterus, and then we slide them down. And I like these because they only put tension at the very end. And we usually put 4 or 5 stitches in the myofascial flaps. And then on the skin, we use a PDS now, and we try to place these about 4 or 5 millimeters apart. And same thing with the melter knot that we slide down. And undermining the skin and trying to get a tension-free closure has really helped get better skin closures, at least in our group. This is a mattress stitch, but these days I usually just put a simple stitch down. Okay, so that's what it looks like after we're done. 2 small openings. When the baby's born, we hope that it looks like this. These are what it looks like when we do relaxing incisions. That's typically what it looks like when the baby's born. We do just daily dressing changes for about 3 to 4 weeks, and those can be done at home. And eventually, it'll heal. And this is that same baby a few months later. These are some other examples of relaxing incisions that are in different stages of healing, and they do not look good. But at least at our place, we've decided that it's an acceptable solution to the problem of skin closure when there's not enough skin. This last year and a half, we've had trouble with skin dehiscence, and this is what it looks like when the baby's born. You can see the muscle flap. The majority of these kids are not leaking CSF, and they, for the most part, get dressing changes for 3 to 4 weeks. Some centers have brought them back to the OR with plastic surgeries to do a closure, and that works well too. This is an example of me making a mistake with silk sutures. When we started to have this trouble and not getting input from plastics, when we started to have this trouble with skin dehiscences, my feeling was that maybe the knots were slipping. So I wanted something that was braided, so I went to silk. And for about 4 or 5 cases, we put silk stitches in the skin, which isn't a good idea because there's usually some inflammation associated with using silk, and so almost all of those were dehisced and needed either wound care or a trip back to the OR to repair. And had I just talked to plastic surgery about this, I would have had a better outcome. But now we're using PDS, and this baby was born last week, and there's no dehiscence, and hopefully we'll continue that as we go through. But it's been difficult in some circumstances, especially when the skin's under tension. So a little bit about our results. This is all the cases we've done from 2011 to 2021. There were 277 myelo repairs. To be in this study, the fetus had to meet criteria for fetal surgery. There were 206 of those. And then if the mom met all the criteria, we talked to them about doing fetal surgery. There's about 181 of those. 34 still wanted postnatal repair, and they're in this group of 59. There was 147 who had fetal surgery. 41 of those we did open, and that was in the beginning, like from 2011 to 2018. And then the rest are in the fetoscopic group, and there's about 100, and that was from 2014 to 2021. And there's this other group over here where the fetus met criteria, but the mom was not a good candidate, so they had a postnatal repair, and I threw those in with this 59. So in the results I'm going to show you now, those are the 3 groups: postnatal repair, open hysterotomy, 41 patients, and then fetoscopic, 100. And I'll go through these quickly in the interest of time. And this paper will be in JNS. It's in production, so it should be in JNSPs, at least online, by next month. But we were a little bit surprised to see longer gestational ages at delivery. Our median was 38 weeks, and our mean was 36.7. So a little bit longer gestational age compared to open, and a little less prematurity, less than 30 weeks, which is good for the baby. We had no trouble with the hysterotomy sites or problems with the uterine wall. In fact, 50% of the moms had a vaginal delivery. Post-op wound complications were certainly more common in the beginning of this series of 100. We had about a 10% CSF leak rate. So in this column, most of those were in the first third when we did a simpler repair. In the beginning, we didn't do 3 layers, we did a single layer. Since we went to the 3-layer, we've only had 1 leak in the series. I will say more recently that leak rate has gone up, but I think we're improving. Hydrocephalus rates for this, and all these have at least a year follow-up, was 35% in the fetoscopic group. In our hysterotomy group, it was 33%. And for postnatal, just as a comparison, it's 81%. So these numbers are pretty on par with what was seen in the MOMS trial. And we did the MOMS trial criteria to make it a little bit more objective, and we didn't see any differences. I will say that about 5% of the kids in the fetal group have come back after a year and needed treatment for hydrocephalus. We didn't see that in the postnatal group. In terms of tethered cord, at least in our series, we do see a higher rate of tethered cord in the fetal repair group, but those rates are not different between fetoscopy and hysterotomy. So about 17% and 12%, I think the p-value is 0.2. And those numbers are definitely higher than what we see with our postnatal repair patients, especially with most of these kids have about 5 years of follow-up. So it is happening more commonly in the fetal surgery group, but the rates are not higher for fetoscopic. Same thing with spinal inclusion cyst, same story. Higher rates in the fetal repair group, very rare in postnatal repair. Not all of these need surgery so far, but it's definitely more common. In terms of carry 2 crisis and carry 2 decompression, no difference between the 3 groups. We don't do it very often. It's about 2 to 5%. Same thing with trachs and G tubes, and that's not a surprise, I don't think. Our ambulatory outcomes were also better in the fetal repair groups compared to postnatal, but again, I just want to remind you this is not a randomized trial. There is a selection bias. Patients who are paraplegic when they're fetuses tend to get a postnatal repair because there's not much benefit, and I'll talk about that more in a second. But the main comparison group that we're interested in for the study was the 2 fetal groups, and the rates of preservation of motor function are about the same. And the ambulatory rates, and this is a scale taken from the CDC registry, about the same between the 2 fetal groups. About 50% are able to ambulate in the community, and that's with or without orthotics. So we're happy with that. Just to conclude about that data, I'll say when we compare fetoscopic to open, I think we've shown that it's better for the mom. It allows for vaginal birth. You don't have this concern about uterine rupture. And I think we're seeing outcomes that are similar for the baby, which was the goal. We are seeing longer gestational ages, and we are seeing higher rates of tethered cord and spinal inclusion cyst in the fetal group. And we can talk about them more in this discussion if there's time. I did want to say a little bit about prenatal counseling. Whether you do fetoscopic or open, doesn't matter, and whether you have a fetal center or not, it's important to do fetal counseling. I think when you read about this, a lot of people will say fetal surgery is the new standard of care. I don't like to frame it that way because it implies that postnatal repair isn't a good option if you meet all the criteria. I don't think that's true because of the risk. I always emphasize to patients that are pregnant moms that the safest treatment is a postnatal repair for both mom and baby. And it's important to know that fetal surgery doesn't cure spina bifida, because a lot of patients will think that, and even your consultants in other fields may feel like fetal surgery is a cure for spina bifida, and it's not. It really only addresses hydrocephalus and lower extremity weakness, and not completely. And these other comorbidities still have to be addressed in clinic in the long term and the short term. And patients need to understand that. And Jay's work with the MOMS cohort and Dr. Tulipan about ventricular size, I think it's helpful for counseling. I won't repeat that. I also think it's important to look at the movement in the lower extremities prenatally with ultrasound. You can assess movement at the hips and the knees and the ankle. And if it's there, fetal surgery may be able to preserve that, especially if the lesion's high, like L1 or L2. They're less at the risk is not as high when it's an S1 lesion. If if there's no movement and they're already paraplegic, I tell patients not to choose fetal surgery for the motor benefit because it's not going to bring that function back. And then from there, you can refer to a fetal center if you don't have one. And I'll stop there and say thanks.
Bill, that was a great summary. Thanks for taking us through the evolution of to fetal work. Jay, I think there's a natural here. I think it's just naturally fair to give you a couple of minutes to just, respond to some of that. I think some of I think some of Bill's work leads to the impression that that the maternal benefit really is a step forward. And I'd like you to have a couple of minutes. I know you've thought a lot about this. I heard you on a platform one time say, we have dedicated ourselves to decreasing the morbidity of this procedure as our second, third, fourth wave. Would you take a couple of minutes and speak to that, particularly with regard to some of the points that Bill made with regard to some of the advantages of fetoscopic surgery?
Well, I appreciate that. And that was a great presentation, Bill. And I also, in all honesty, commend you for, churning the data for us to understand. And I do look forward to the publication that actually, shows the CSF diversion rates because, we've talked about it before. We've kind of been at a disadvantage within the field because, uh, you know, not having that in the published literature has made it a little bit challenging to know if it is as good for the fetus because I do feel like the purpose of the mom study was on the fetus, and I think it's important that we don't lose the sight of that, and CSF diversion is important. The tethered cord issues are important. Those things that you pointed out in the last slide are important, but also the culture, like I mentioned, the culture of CSF diversion has changed now. We're all a lot more willing to let the size of the ventricles ride, or even the size of the head ride if it's just at the top of the curve and not continuing to go up. And also with the advent of ETB, CPC, there's the whole sociologic issues of parents just feel like the main thing is to avoid the shunt, and they don't understand as much that it's the development of hydrocephalus. So I'm a little bit worried that we're moving the focus of the reason for their initial study, and that is on the fetus itself. I don't. I do think that there are issues with the back closures, and I do think a lot of centers um, around the country that have started to do this fetoscopically are having issues that I would assume that may have happened other than this most recent bump with silk sutures that were originally happening when you began to do the surgery. And a lot of other centers are also not choosing to do the rotation of bipedical flaps, but to put the patch across the middle. And it's just become Wild West on the fetus. We don't know. Again, I'll take a bullet for Bill Whitehead, but you did just arbitrarily decide to put silks in. And that's a change that had a big impact on the fetus. And that would be the same thing that's being done now when the patch is being sewn in the middle. That's an arbitrary decision, that we don't know what the effect of that is. And we don't have any publication on the effect of that. And if you have one center that's done 100 of these and other centers that have just done a few of them, those centers still have, I think I heard you say it may have taken you 50 cases to get comfortable with this. And so that means that it's not reproducible. And so that moves me to my second point, which is, in my opinion, the whole goal of the mom study when the handshake was made at the beginning, when only 3 centers would do it, was that now we will disseminate this across the field. And that's what was happening. And now that's reversing, and it's now moving to be sequestered in centers that just do it this way without there being a standardized way to do it, and without there being at least substantial data that shows us that that's as good. I think the third point to make is that you mentioned it, is that the dehiscence rates, I think they've redone that study and it's going to be published in pretty soon, looking at the NAFNet cohort and uterine dehiscence. And I think that number is going to be substantially reduced from what the original numbers were. And I also know that, here at our center, we don't make a size that large anymore, but what happens is, and I can't quote the exact times, but the recommendation is to wait for 18 months to 24 months before another pregnancy. And then at that time, an ultrasound is done to look and see if there's any evidence of dehiscence. And if there is, surgery is done to take out that area of dehiscence. And then there's been multiple mothers that have been able to go on and have subsequent pregnancies. And I just looking at the data, is it worth a 50% rate of still needing to have a C-section? And is there?
Let me just exercise moderator prerogative here, just for time's sake, because there's a number of issues and I know Professor Leonard's going to lower the time boom on me here at some point. Okay, so hey,
We might
Bill.
have talked for like an hour and a half.
I know, right? Right. Well, it's a very interesting conversation. It really is. And Jeff, if I may, I'm going to exercise prerogative and go a bit overtime here. I'd like to give Bill a couple minutes. I don't want to play ping pong here, back, forth, back, forth, back, forth. But these are really
We're
important points.
talking at the section meeting and at the ASPN.
Yes.
So there'll be time for further discussion on
Yeah,
that.
absolutely. And I think it's important. That's a really important point, Jay. This is not definitive, but this is a taste of what listeners should anticipate. But I do want to give Bill just a couple minutes, and then I want to throw out a couple of questions about NavNet, about neurosurgery involvement, about expansion of this. There's a lot of topics to touch on. So, Bill, can you, in a couple of minutes, are there any comments that Jay's three or four observations that he shared in response to your program that you want to respond to?
Yeah, no, just a few. I mean, when we put together these numbers, we included the placebo group as a comparison because things have changed in hydrocephalus since the MOMS trial. And so these are ATV, CBCs, and those numbers. It's not just shunts. It's anyone who was treated for hydrocephalus. And we included the postnatals as a comparison. Now, it's not a randomized trial, but I do think we're seeing similar results. And the other thing is, it's slow, right? I mean, this is still a pretty rare disease, and it takes time. It's taken us a long time to get to the point where we are. I'm very happy with the program now. I think the skin dehiscence thing is fixable. It wasn't a problem in the beginning, but it is a problem now. But it takes time, and now studies have to be done to compare this technique to other techniques, and it's a slow process. And the last thing I'll say is, there's different types of endoscopic techniques. There's percutaneous, and so when you don't externalize the uterus and tack up the membranes, that's a different approach, and it's got to be evaluated separately. And it probably needs to be done more with registries than a randomized trial. I don't think we're ready for a trial for this, but those were our goals, and it's taken a long time. But that's one of the problems with this field, in terms of there's just not a lot of patients, and there's not a lot of fetal centers to do this at a larger scale.
Bill, that's a great segue into the next point that I was hoping to make. You commented about registries, right? And as an enthusiastic sideliner on this, I've watched the development of NavNet, and I've watched there grow more and more centers with, as you just allude, further and further dilution of a limited number of patients, modification of technique, such that it seems that now we have a larger, you just alluded a small number of centers, but relatively compared to 3 at the beginning, we're up around 30 now, just shy of it. How does NavNet compile data? What agreements do the centers all have amongst themselves? How is that registry being moved forward to try and address some of these questions rather than just being a dump zone for anything that anybody doing this work wants to put in there?
I don't know exactly. There may be others who have more details on the NAFNet registry, but last time I checked, it was just for open hysterotomies. They were not including fetoscopic cases,
I
which
see.
I think is needs to change because more centers are moving to fetoscopy, and that's probably the best group to combine the cases with.
Jay, any comments on NavNet?
Yeah, so the neurosurgery part of the NAFNet database has been woefully inadequate, and we've known this for quite some time. And we actually I've just last week spoke with the head of the scientific committee of NAFNet, and we're planning on putting a proposal in for there to be a specific study on the different closure types, and with the idea of there being more variables inserted into the database. Because, as Bill and I know from the HCRN, if you don't measure it, you can't study it, and it ain't being measured right now. So I think you're exactly right, Jeff. And we're behind in getting the variables that we need to be able to understand.
Is there any governing alliance? Not, I don't mean forcing people, but this trial was striking in its discipline early on. Everybody stopped. There was a moratorium so that the three centers, and then just like Jay, you alluded earlier, it's now inverted where it went from great discipline to now it's everywhere. It's almost from the original centers, it's almost a billboard program now where centers, medical centers that in the past don't have any kind of longitudinal commitment to spina bifida as a problem are developing a program or bringing a program to basically apparently show to their subscribers, their people in their area, the blank clinic, the such and such system will bring the state of the art care to you. Is there any way that you guys can think of as active members of this community to curb that so that there is some organized structure moving forward so that we can learn?
Bill, you want to go back and forth with me taking one first? Is that all right with you? Like you took that one first, then I'll take it.
Yeah.
Yeah, I mean, I don't have a perfect answer. It's a problem, um, but the solution is neurosurgery showing up. And most of these things are run by maternal fetal medicine and pediatric surgery. And we have to stay involved at NAFNet, um, at fetal meetings, because our input is important, but their input is important too. And if we just try to do it on our own, it's not going to work. I don't know what to tell you about these fetal centers that pop up without a lot of support in the spina bifida clinic. That's always a mistake if you don't have a team to care for these patients. And the mistake is on many levels, but the biggest thing I see is when you don't have that, your outcomes are poor and it kills your program. So you're shooting yourself in the foot from the very beginning.
Great. So you guys have each dedicated large parts of your careers to developing these techniques, right? And a significant component of the listenership of this webinar are presumably young neurosurgeons coming up, residents, fellows, people in their early part of their practice. What advice would you two guys give to a young neurosurgeon with potential interest in developing a practice in fetal myelomeningocele? Not making us fetal surgeons, but this specific neurosurgical component. Bill, I heard you say it was one of the international meetings. It was striking how meticulously it reminded me of the 10,000 hours rule, right? And the Beatles in Berlin and all of those analogies, right? And I know, Jay, you've put similar time in. I just heard Bill allude to it from a platform. How do you learn this? I mean, just most simply stated, how does one in 2024 who's motivated, smart, and dedicated, how does one learn this?
I think my answer to this is going to be probably easier than Bill's. I mentioned in the diagram that in the paper that Dewan and I published in the JNSPs and the Diamond Anniversary. Right across the table for me is the neurosurgical trainee. So it may be a full professor of neurosurgery and a full professor of plastics, of MFM and a full professor of plastics waiting in the wings. But like I said, it's a PGY3, 8, or fellow that's across the table. So, that's been the tried and true method. Now, not unsurprisingly, who is it that holds these, um, you know, the the referral strings, and that is the MFMs. And so,
Yes, very
so
important.
that may very well completely go over an established open program to go to an unestablished fetoscopic program. So that goes back to your initial issue or your second question, which is we do have to publish this data so that once we measure it, we publish it, then we complete it. But in terms of people that want to get into the field, I think you have to associate yourself with a good fetal clinic. Bill had a great slide showing all the people that it takes to do this work. It's not just Noel, it's not just a neurosurgeon and a MFM and a neonatologist anymore. It's a huge field, it's a huge group of people. So I think you have to associate yourself with people that do this work. And then the last thing I'll say is that you have to be willing in your own career to be able to do a complete 180. And the worst word that came up in American politics in the last 15 years is flip-flop, because it's taken away the ability of people to change their mind and evolve in what they think. And when I was at UAB, we had a terrific practice. We elected to not do fetal surgery because we were part of the control studies for the pre-mom studies, and we saw that there did not appear to be any significant difference. And then the mom's trial came out and it was different. And so I had to be willing to go to Vanderbilt. I was the doubting Thomas. I wanted to see holes in the hands and the sword wound on the side before I would believe that, fetal surgery would make a difference. And because I was a member of the HCRN, I was able to use that lens to understand the mom's data and the mom's investigators better. So I think from an early standpoint, you get yourself involved with a good group of people and a solid center first. And then when you're later in your career, you've got to be willing to change.
Very good. Bill, share with us
And
because I know you've spoken about this before, your
so,
Beatles in Berlin time, basically.
um, so if you want to do this, go to a training program that has an established fetal center and do cases. That's number one. And then number two is when you pick your job, um, go to a place that has a fetal center, or they may not be doing myelomeningocele, but they're doing other things. If they're just starting from scratch and they're not even doing much prenatal diagnosis or prenatal counseling or some of the easier procedures, it's going to take years before they can do hysterotomies or fetoscopic. And if the MFMs aren't involved, or if there's resistance on that end, it won't happen. Like, the patient is the mom, so you've got to pick a job. They may say they want to do fetal, but you've got to talk to the MFMs, and they've got to really want to do fetal and have already made steps, because neurosurgery can't do it on their own. And I do think this needs to stay in neurosurgery. The reason I put time into learning it and doing it is because it's a neurosurgery procedure. It does, like anything else in neurosurgery, it takes time to learn. But I don't believe this should be done by other specialists. I do think it's a neurosurgeon should continue to do it, and that's why I've done it this way.
Yeah, I think that's an important ending point, particularly in light of a landscape that has at least one program now where there's no neurosurgical involvement. That I think that the strong message from neurosurgery is not for self-interest, but for longitudinal perspective and fundamentals, that neurosurgery really does need to be central to this. Guys, I think we'll wrap it there. There's, as you both alluded, there's hours more conversation to be had. This was a wonderful conversation. I thank you both very, very much. And Jay, lots of great comments, but the one that is most apt for the moment is that you'll both be discussing this further. So that's a nice lead in for everybody who's watching this webinar to make sure that they, if they possibly can, attend the pediatric section meeting, and those that are interested, enable the ASPN as well. So the conversations will go forward. It was a wonderful conversation this evening. I don't know if Toba's back. I don't see her. Toba, if you're back, I'll turn it over to you. Otherwise, okay, great. So we will thank you for allowing us to talk about spina bifida for an hour, and particularly thank these really great speakers for for such an engaging and a little bit, different perspectives, but civil conversation. We could use a little bit of that more in our political life. All right, Toba, thank you.
Thank you, guys. Thank you to all.